Hi, good afternoon, everybody. Welcome to this webinar. Um, my name's Esther Youd. I'm an autopsy pathologist based up in Glasgow. I also chair the Royal College of Pathologists Death Investigation Committee. And we as a committee have put together this brand new series of autopsy webinars in order to provide some CPD opportunities for training pathologists and practicing pathologists. We are really excited. We've got quite a varied programme coming up, and I'm just going to share my screen and show you some of the topics that we have coming up and dates. So today we've got Sophie Wallace talking about when to refer to a forensic pathologist. And the next webinar that we have is Drug-Related Deaths by Julie McAdam on the 19th of June. Now that is available to book online on the college website. The other dates are confirmed, but we will make the booking available on the website in the coming weeks. So you can take a screenshot or photograph of this now just to put the dates in your diary, and they'll be available for booking very shortly. I am just here to introduce this webinar series and to welcome you all. And I'm going to hand over now to Ben Swift, who is going to chair the rest of this session.
Thank you, Esther. I'm Ben Swift. I'm one of the Home Office registered forensic pathologists currently working within England, and amongst other titles, I'm also series editor for the Royal College Autopsy Guidelines series. So as Esther says, I'm here just to chair the session. Today's webinar, the When to Refer to a Forensic Pathologist, is going to be presented by our speaker, Dr. Sophie Wallace. Now, after Dr. Wallace's presentation, we'll have a short Q&A session. If you wish to ask a question, then use the Q&A facility at the bottom of the screen. Please note that the webinar will be recorded and uploaded to the RCPath website in the coming weeks, and that includes the Q&A session as well. And that any attendees who are present can self-credit a CPD point for attending the webinar. So the session, as I say, is to be presented by Dr. Sophie Wallace, who is an ST6 Forensic Pathology Registrar at the East Midlands Forensic Pathology Unit in Leicester. She's spent the last 5 years in an apprenticeship type role, currently with the 3 consultants in the unit, assisting with postmortems on suspicious death investigations over 5 counties. She regularly attends courts to observe witness testimony and assists at crime scenes, and has undertaken a lot of teaching for medical students and general histopathology trainees. She also sits as the forensic trainee representative on the Death Investigation Committee at the Royal College, and also on the Autopsy Pathology Committee for the Association of Clinical Pathologists as well. So if I now hand over to Sophie. Thank you, Sophie.
Thank you very much. Good afternoon. So I'm going to be talking about when to refer to a forensic pathologist, and this is really aimed at general autopsy pathologists, but also trainees across the UK. I'm going to be talking about some specific case scenarios that will crop up within your line of work, and just what to think about with these kind of cases, and some practical advice with approaching these types of autopsies in terms of the history, the external examination and the internal examination. So I'm going to run through a little bit about just a bit of background about police and scene investigation and some of the changes over the years. And then I'm going to be talking about an update that's going to be happening on one of the autopsy data sets, which is currently looks at the potential for suspicious deaths, and it's aimed at general pathologists. This has not been updated for about a decade. So Dr. Kolar, who works in the West Midlands as a forensic pathologist, has written some guidance that will be released soon, and provide some really useful documentation on indicators of suspicion, which I'll be going through. And that will cover some specific scenarios that he's pulled out and some case examples. As I say, some practical advice for you at the autopsy as to what you should be looking for or thinking about. And then just a little brief bit at the end about code of practice and the guidance that's available on the website and the wording that's applicable to you. So as you know, there are 2 types of autopsies. There's a non-forensic coroner's or a general autopsy. And then there's a forensic autopsy, whereby the death is already considered suspicious, or they're not quite sure and they want a forensic pathologist to look at it. And England, Wales and Northern Ireland, it's the coroner and the coroner's office. And in Scotland, they have the procurator fiscal and the Crown Office and Procurator Fiscal Service, which I'll be referring to throughout. So roughly, statistics-wise, in England and Wales, there are about 500,000 deaths a year, and a medical certificate of the cause of death can be issued in about 300,000 of those by clinicians, which leaves 200,000 which are referred to the coroner. Out of those, about 80,000 have a post-mortem requested, and within that 80,000, there are 2,000 that are already treated as suspicious and go straight to forensic pathologists. It's a little bit more difficult to find some of the data in other areas. The data I could find in Scotland was that there's roughly about 65,000 deaths per year. Medical certificate of cause of death is issued in 50,000, and the Crown Office and Procurator Fiscal Service receives about 16,000. So these deaths that occur in the community are usually attended to by the police, and they conduct an initial investigation at the scene on behalf of the coroner and procurator fiscal. So forensic cases. Forensic cases are referred to either a forensic pathologist on the Home Office register in England and Wales, a state pathologist in Northern Ireland, or an NHS consultant forensic pathologist based in Scotland. And the whole of the United Kingdom provide a 24-hour service to police forces, but also the coroner for any suspicious deaths where advice may be required. However, England and Wales is in really stark contrast to the rest of the United Kingdom and also the rest of the world. So in the United Kingdom and the rest of the world, medico-legal autopsies are conducted by a forensic pathologist who are employed by the state. Whereas in England and Wales, the practice is independent and they work within a group practice. So they have to have a minimum of 3 working with a practice, so they are not working independently. So the decision-making process up to the point that a sudden death has been discovered prior to the post-mortem is fairly robust. And in the vast majority of cases, the processes that the police and scene investigation people do result in appropriate referrals. But inevitably, there will always be a small number each year which will slip through the net. And this is what we'll be looking at today. So just a brief look at the scene and just thinking about what happens at that initial assessment before the body even gets to you. So a death will be discovered, possibly in the home, somewhere out in the community. It can be in a wide range of places, and a police officer will attend. And they'll then make a decision as to what to do next. It may be that the paramedics need to be called, possibly in order for resuscitation or just to confirm death. And the forensic medical examiner may also be called out if they're concerned enough about injuries or the circumstances or the scene of the death. This decision-making process right at the start of the scene of a sudden unexpected death has a huge bearing on cases, and that may be referred then to a non-forensic medico-legal autopsy. Paramedics are very good and experienced in dealing with quite acute situations and looking after people's health when something has happened that requires a response quite rapidly. However, they aren't necessarily as accustomed to seeing those that have maybe died recently or over a longer period of time, and so they may not be aware of some of the pathophysiological changes that you can actually see. And so it's been shown that there's actually been more of a reliance than probably is necessary along paramedical staff and forensic medical examiners to provide an opinion, which then assists the police as to what to do. And sometimes this is based from people that haven't necessarily seen all the changes that they would expect. So the College of Policing released guidance to support their police officers in 2019, and this really provided some practical advice to them as to how to deal with a sudden unexpected death. And this is the sort of flow chart that they came up with to use. And as you can see, the bottom right-hand corner is where suspicious deaths slot in. And the main avenues for it to turn into a forensic post-mortem is the police investigation side, but also the non-forensic post-mortem element where you slot in. So until recently, before those guidelines were released, there weren't any nationally accepted guidelines for the police, and systems and practices really varied widely across the country depending on what each police force did. And research has gone into that, which has produced this guidance. But in the process of that research, they found that there was a risk of poor practice and poor decision making. And the main areas which they focused on in the research looked at the underutilization of crime scene investigators. So these are investigators who purely deal with scene management, collecting trace forensic evidence and managing a scene, and they go to a lot of scenes, possibly more than the police officers who are initially attending, and can provide quite useful advice but weren't necessarily being asked. Inexperience of initial attending police officers, they can be quite newly trained or not had any training, and so they found that to be a difficulty, that they were then having to make decisions possibly beyond their experience. And then even if they did find something, then a lack of standard operating procedures as to what to do next. They found that there was an inappropriate use of, we've talked about, forensic medical examiners and other paramedical staff, that there were financial considerations involved in the decision making, and that there was an inherent bias and a sort of assumption that it wasn't suspicious when actually it should have been considered suspicious with a bit more thought process. But also just really thinking about the vulnerability of someone when they've died wasn't always considered. So specifically looking at the young, the elderly, medically incapacitated or the intoxicated, and how they got into the position that they did at the scene, and just really thinking through the process of the scene. So we had a case a couple of years ago now, whereby we were referred a case due to the fact that a 58-year-old man had died, and he was found in his property, which was a secure property. The police didn't have any concerns about his death, and there wasn't anything at the scene that raised concerns. However, the main red flag for them was that the paramedics thought that he had been punched in the eye and therefore required a post-mortem, and further examination at the scene also identified possible petechial hemorrhages. When we received the case and it turned into a forensic post-mortem, when we looked at the case, actually we found this pathological finding, which is tache noire, which actually occurs with the separation of the eyelids causing drying of the eye, and you then get this artifact of tache noire, and that was misinterpreted by the paramedics as a potential assault. So the Forensic Pathology Specialist Group conducts an annual audit of forensic pathology reports, and they do this on behalf of the Forensic Science Regulator, although we're not regulated anymore under them. They're there primarily to monitor the standard of forensic autopsies, and back in 2012 a theme is picked for the audit, and the forensic pathologists all hand in a report around this theme. And 2012 it was where a forensic pathologist had to take over a case that had already been started by a non-forensic pathologist because concerns had been raised about the fact that it was potentially suspicious. There were 32 cases submitted, they were all made anonymous, and then an audit team which consisted of 4 forensic pathologists, a coroner and 2 police senior investigating officers then looked at the results. And actually from this audit, they considered that all of the cases should have been forensic autopsies from the outset. And the results then prompted further research by the Home Office into the nature of these cases, which I've then talked about in terms of the police and scene investigation. At the time, 10 cases were confirmed as a homicide by the police investigators and the coroner. And then some remaining cases were classified as open verdicts, and that's because there was no cause of death that could be reached at inquest for a variety of reasons. And as a result of this process, it's now mandatory for these cases to be reported, so the Home Office can look into it, because it's not just about the pathological element and the post-mortem, but also the police and decision-making investigation that happens before. So where do you fit in on this? So non-forensically trained histopathologists conducting autopsies should therefore have an awareness of the types of cases and the pathological features that should raise concern. It is certainly not expected that at coronial autopsy, a pathologist should be able to absolutely distinguish between a homicide or not, because that is not your role as a general pathologist, but you should simply feel that you are in a strong position to stop that autopsy and recommend a referral to the coroner if you feel it's appropriate. So why does that autopsy need to be stopped? There are a couple of reasons to think about. and it's important to try and stop early if you're at all concerned. But there's a potential loss of forensic evidence that might occur if you continue. That there can be real difficulties in the interpretation of the autopsy findings by the second pathologist. So when the second pathologist, the forensic pathologist, comes in, they will restart the autopsy from the start and go again. But if organs have been removed or incisions made, it can then be really difficult to interpret to the point that they may not be able to comment. There can be a potential for a missed opportunity to ensure that justice takes place, and the possibility that the pathologist carrying out the initial examination may be called to give evidence in criminal proceedings in court, which is something we want to avoid you as general pathologists having to do if there's a specialist and an expert in that field, a forensic pathologist, that is accustomed to doing so. So I'm going to talk a little bit about this updated autopsy dataset, which will now be version 5 when it's released. Indicators of suspicion. There are a fair few times that you can see and look at. Let me start again. Indicators of suspicion. There are a number of times within a post-mortem where you might be concerned about what is the examination of the deceased that you're looking at. It may be in the history, and after you've read the history that you're not happy. It may be after the external examination where you're not happy with the injuries and whether they correlate to the history. And it might be the internal examination. You might discover something that you are not expecting to find. At various stages, suspicious features may become apparent, and so the pathologist must reassess continuously whether or not to continue with the examination. So there's not just one point in an autopsy where you feel the need to stop, because you may find something along the way, and that is completely understandable. So the history of the incident and the background of the deceased is a real vital component of the investigation, and it gives you your pathological findings a context. So if you don't have a history, it's inaccurate, you think it's missing vital information, that means that you actually can't interpret the external findings and further internal, then you should be thinking about whether you should be asking for more information and raising that. So you'll normally get a report from the coroner's office or the Crown Office and or police investigators regarding the circumstances. So you might be given a description of the scene, you might be given witness statements, you might be given an idea of what the scene looks like, and any relevant background information that's important to that deceased. You should be getting past medical history and GP records, and where relevant, hospital medical notes, certainly if they've had an admission recently, because that might give you really useful and key information. If you don't have that information and it's incomplete or it's scant, then you should definitely refer the case back to the coroner's office or the Crown Office in an attempt for more information to be provided, and stop that autopsy at that point and give them the opportunity to provide you with more information. Sometimes it's not always clear from the officers what information it is that you're initially requiring, so it's perfectly reasonable to then ask for more information so you can make that decision. So moving on to the external examination. External findings may be of the utmost importance following trauma, and it's definitely not feasible for you to adopt the approach of a forensic medico-legal examination. We have the police that are present, they take photographs, and external examination can often take hours, and that's not the role within the coronial system for coronial and non-forensic cases. But it is paramount that you really think about what you're looking at in an external examination, and that you're happy and the correlation of the injuries is consistent with the history that you've been provided. So these are the scenarios that Dr. Kolar's talked about in the autopsy dataset. I've not got time to go through all of them, so hopefully I've got time to go through the ones in bold and really just pick out some key features that I thought would be interesting and helpful when looking at coroner's cases. So hangings. Practice really varies across the UK as to what the coroner is asking you to do. And increasingly, there are requests from the coroner for an external examination with toxicology. And it's certainly forensic pathologist's opinion that actually from that investigation and examination alone, you're not able to ascertain whether there's third-party involvement, and it's not something you can rule out. Hangings, looking at the background information, it's really important that they've given you information that you can distinguish between a complete versus a partial suspension. And the reason being is that the pathological findings can really vary depending on the type of suspension you're dealing with, as well as the type of ligature. So ligature marks are usually incomplete in a complete suspension hanging. And by that, I mean that there's a suspension gap at the back. So in a complete suspension, the body is sitting under the weight of gravity and pulling down, and that's causing complete compression of the neck, but also the head is tilting away from the ligature, which is where you then get this gap where the ligature is not pressing on the skin, and that might be at the back of the head, it might be on the side, or it might be at the front, depending on how the ligature's been put up. The ligature mark from suspension does not usually encircle the neck, but you need to think about the scenario that you're given, unless a slip knot has been used. So if a slip knot has been used, it means that there's a lot less movement of the ligature, and that it's going to sit a lot more tightly and press against the skin. If there is any discrepancy between the observed injuries and the mechanism that you've been told about, it would be appropriate to stop the examination, and that's before the neck is incised. The real difficulty with hanging cases is if the neck is incised or the examination is started and then stopped much later on, it's very, very difficult to then comment on any pathology that you might see in the neck in a second examination. So this is just really a reminder as complete versus partial suspension. On the left is a complete suspension. So as I said, that's the full weight of the body under gravity. And that's where there isn't any part of the body touching another surface. So there's completely suspended off the ground. Knees and feet are also away from any other objects. Partial suspension, you can get a wide variety of partial suspensions, and this picture I think is a really good example of that. So it might be that they're on their knees, that they're on their feet, that they're even sitting. They might be hanging from a doorknob or a radiator. The height is not necessarily the most important feature. It's the compression of the neck that is key. So this is a picture just to show that suspension gap. So this man's head is tilting away from the ligature towards the left, and the ligature is then sitting on the right side of the body. Once that ligature is removed, you won't get any ligature impression on the right side, apart from where the knot is. And this just shows you autopsy. So this is quite a thin ligature with quite a deep furrow and parchmented. And as you can see, hopefully you can see my mouse, but you can then see it starting to rise up at the back to then form a suspension gap where the ligature was said to have been placed. So other things to think about in hangings. Scratch marks can be suspicious of inflicted injury, but actually you can also get these in self-inflicted cases or accidental suicide victims. So it's not necessarily completely indicative of inflicted injury, but it's worth considering what has happened in the scenario you've been given. Petechial hemorrhages are much more frequent in partial suspensions. And the reason being for that is that, yes, a complete and a partial suspension will both cause a compression of the neck and the internal jugular veins. In a complete suspension, the theory being that you don't get any petechial hemorrhages because the arteries are also compressed under the weight of the body. However, in a partial suspension, that artery is not obstructed, and so you are still getting blood flow into the brain and the head region, and then the pressure is building up because the blood is not able to exit. And that's where you get a build-up of pressure and then rupture of the venules, which is why you then get these petechial hemorrhages. It is a myth that fractures of the larynx and or hyoid do not occur in ligature suspension. This was a few years ago now, but at the time with Jeffrey Epstein's suicide, he hanged himself in his prison cell. And shortly after the post-mortem, information came out that his hyoid bone was fractured. And there were quite a few forensic pathology experts in the US that came onto the news very quickly and said that this couldn't possibly be due to couldn't possibly be due to a hanging, and actually this sign was indicative of strangulation, and that's not always the case. You can certainly get fractures with hangings. So this is just an example of a fractured hyoid bone here. So this is the hyoid bone at the front of the picture, and this sharp angulation here is as a result of a fracture. And the next step after this is to really dissect down the soft tissue and see whether there's any bleeding around the hemorrhage and the significance of that, and also looking then at the surrounding soft tissue. So the external examination of the neck, some cases can be extremely subtle, and so there should be a really low threshold for stopping the autopsy. You can get localized trauma in the neck structures underneath, and the effects of pressure to the neck away from the neck itself. So you should be looking for those asphyxial signs we talked about and whether they're consistent with the history you've been given. Petechial hemorrhages are not a finding that's unique to the pressure of the neck, as you'll know, and they can be seen in a number of other scenarios. So it may be in the context of resuscitation. It may be if they've died and they've been laying in the prone position for a number of hours. And you can also get them in raised intrathoracic pressure from repeated vomiting. There are a number of other scenarios that you can get them in as well. So this is just to give a really good example of petechial hemorrhages. This is in the lower eyelid. You can see lots of pinpoint hemorrhages. And again, if once closing the eyelid, you can also see quite a large number of petechial hemorrhages here. A heavily congested face with florid petechiae and an encircling ligature mark should be considered atypical of ligature suspension, and you should certainly be referring these cases back to the coroner or the procurator fiscal. And by florid petechiae, I mean an example like this. So if you can see, just starting at the eye, you can just see the tarsal plate there, but there are numerous petechiae. There's scleral hemorrhage here, but there's also a number of petechiae all over this man's face. It's across the bridge of his nose, it's around his eyelids, it's up to his forehead. So that should definitely be sending warning signs that this isn't consistent with the history that you were expecting. This is the same gentleman who actually also had petechiae on his mucosal lining as well, so it just goes to show you how widespread it was. I just thought I'd run through very briefly what it is that we actually do as forensic pathologists in terms of neck dissections, as it's not a standard procedure for a general pathologist to do. So just to remind you of your anatomy, this is the sternocleidomastoid sitting on the right side, which will be dissected back first. And the reason being is that for each layer that we then dissect, we're looking for signs of hemorrhage that may be significant, or other disruption as well, depending on the history that you've got. So this is the sternocleidomastoid. You've then got the omohyoid, which has a superior and inferior belly, which can be dissected back. And then you've got a set of muscles that are sitting adjacent to the midline either side, which is the sternohyoid and the sternothyroid, which will then reveal the thyroid gland. And I've also got images that have been taken at autopsy just to make it a bit clearer. So this is a Y-shaped incision that is done by a number of forensic pathologists. In Northern Ireland, they actually do it from clavicle to clavicle and make a horizontal incision. As long as the neck muscles can be seen, that's really the main aim. So here we have the left sternocleidomastoid sitting. Once that's dissected back, you can then see the internal jugular vein with the omohyoid being pointed out by the probe. And the sternothyroid has been dissected back already, and then this is the sternothyroid that's being held by the forceps, which then reveals the thyroid gland. And you're able to see either side of these muscles as to what's going on, because you can get very deep structures that are then damaged, which are not always obvious when you initially start the neck dissection. And you can also then look at the vessels and whether you're concerned about any damage there. That's the internal jugular vein being opened up and the carotid, common carotid. And then finally, this is also done at general autopsy, but can be seen a lot clearer following a Y-shaped incision. You then start to cut away at the floor of the mouth and the muscles, such as the mylohyoid and the genohyoid, the digastric and the stylohyoid. So those will all come away, and then you're able to pull the tongue back. And it may be that you see more soft tissue injury and bruising then. So these are some really good examples as to actually what's apparent on external examination and what you're then seeing internally. So on external examination, there's very little mark. There's a red mark there, probably a bruise, but actually there's very little else to this neck. And then when you look, you can see that there's bruising in C, which is really significant on the right side. And the same here in B. This is quite marked lividity, so this is all decomposition and post-mortem change that is normal. Very little marking on the neck. And actually, when you dissect it back, you can then see there's quite a lot of hemorrhage that you wouldn't have seen externally that may not be consistent with the history that you've been given. We've had a scenario very recently, back in 2019, that looked at this. It was a case of a gentleman who had died in a property, and there were 3 other people present. There was a male and 2 females who were sex workers who stated that he had taken cocaine and died, and that was all the information that the police had gleaned. This was actually the death of someone who was well known by the police, and so although raised concerns, they couldn't see anything particularly suspicious about the case, and so it was listed for a routine post-mortem. Actually, new information came to light just 24 hours later, as the 2 females walked into the local police station to say that actually that wasn't the case, that the other male had the deceased in a chokehold and held him there until he then dropped, and they think that's why he died. So this was just about to be listed for the next day for a routine post-mortem, and actually the police changed their decision rapidly, and it went to a forensic case. There was no external markings on this case at all, but there was hemorrhage on the left side of the sternocleidomastoid, but you wouldn't have seen anything externally. So another scenario is looking at head injuries and recent assault. Head injuries are commonly caused by accidents as well as assaults, and so you need to think about the background information you're given and whether it's fitting with what you are seeing at post-mortem. Certainly on external examination, really consider that the injuries that may be concealed on the scalp by hair, if they've got a lot of it, or it's very dark hair you can't always see. A fall onto a flat surface may leave no external mark. Falls onto flat surfaces will usually injure the occiput or the forehead or the parieto-temporal areas. So just think about those bony prominences if someone's falling as to where they're likely to hit their head. And a fall from a standing height can result in a fatal injury. So thinking about something like a punch, which has forced someone to fall backwards and hit their head, that can certainly be fatal in terms of the injuries that they can get from standing height and then falling. And a fall onto a flat surface would not be expected to result in a depressed skull fracture. So if you've got findings like that, you should raise concern that it is not as simple as a flat surface to cause this. Other features that would raise concern include injuries above the hat brim line, injuries that don't adopt the typical profile of a ground contact, as I mentioned, and just the extent and the frequency of injuries in a localized anatomical distribution. If you've got a large number of bruises or abrasions or marks over the head that are sitting on multiple different planes, just really think about the history you've been provided and whether that correlates with what you are seeing. External examination looking at the face, they can be a really common target for assault, but also actually they can be commonly injured in the context of a fall. So in a fall, injuries are typically associated with abrasions or bruises concentrated over the bony prominences. So that's the ridge of the eyes, could be the nose, maybe the cheek. Whereas assaults typically result in bruising, particularly around the eye, so within the eye socket, the nose again, but also lacerations, so bruising, abrasions, or lacerations around the mouth. And this distinction is not always clear cut. So it isn't as simple as if there's a mouth laceration, it must be assault. It needs to be taken in the context of the history that you've been given. But definitely look at the lining of the mouth. It can give you a lot of information in terms of occult injuries, stability of the teeth if there's been assault, or maybe a tooth has fallen out, and also foreign bodies that you're not expecting. So this is an example of what a head looks like in external examination, where you're not able to see the injury, but actually if you shave part of the hair, you can then suddenly see there's an abrasion to the back of the head consistent with a fall to the ground. This is another example where there's absolutely nothing over the left side of the neck that would raise concern. But then on the left side of the jawline, you can see a bruise, which would, you then need to think about the context of the history you're given, because there could be a number of possibilities for this. And are you happy with the story that you've been given? The third scenario, historic assault. These ones can be really difficult, I think, as a general pathologist, in terms of the information that you're given. So a significant assault may result in persistent brain injury, and that can include epilepsy, but the death can arise due to medical complication months or years after the event in question. And I think when you're given the information, it's not always clear actually what the cause of the brain injury was, or it's forgotten to be mentioned to you, which is really important. This information you should definitely seek out from the office, as this might have criminal implications if at the hand of another person. So if they've been and sustained a really nasty assault and they've got long-lasting brain injury and subsequently died, and you feel that the brain injury plays a role in that, then it may be that someone is culpable and is a factor in this person's death. Dr. Swift and I were talking earlier in the week about cases. We've had one in the unit, and he has as well, of cases whereby a young adult has died, and actually the brain injury is found to have been caused by shaken baby syndrome a lot earlier. And so it's just putting together all those pieces to make sure that you're absolutely happy that you know why they've got what they've got. Road traffic collisions. This really varies up and down the country. So the practice as to who performs these autopsies varies between regions, between coroners, and they can go as a general coroner's or a forensic autopsy, and it's really dependent on the scenario in question. So if it's a case by death by careless or death by dangerous driving, these should be referred to a forensic pathologist. You need to really consider the background information in these and really think carefully, does this have the potential to end up in a criminal prosecution in Crown Court? And that includes delayed deaths as well that we've talked about as a result of the incident. If it looks, or you have an inkling, or you suspect, or you've not been told but you need to ask if there is the potential for a criminal prosecution, then this should be referred to an expert, being the forensic pathologist, who is used to dealing with these scenarios, and it's part of their job role and their remit to attend Crown Court to give evidence in these cases. Certainly the following cases should be undertaken as forensic cases. So complex pedestrian collisions, collisions in which there is a requirement to match the deceased to a vehicle or to a particular compartment within a vehicle, and also bodies lying in the road with the differential of being struck in an upright position or being run over. We've had a case recently in the unit where it's actually not clear if the person has fallen from a height, has been struck by a vehicle, or both. And so that's information that takes a lot of teasing out and a lot of police investigation, and so wouldn't be suitable for a general pathologist. Decomposition and fire deaths. So don't always assume that a mutilated, decomposed or burnt body will produce no evidence, because actually if you look really closely and get past the natural changes that happen after death, there can be a lot of information, and external examination can still show some really significant injuries. Watch out for mimics on external examination in terms of decomposition and actual injuries, and I'll go through those in a little bit. But mimics to consider in fire death include heat fractures. So that's where, due to the heat of the fire, it's caused bones to fracture as a result of the heat rather than trauma. You can classically see this in the skull, where the outer table might be fractured, but the inner table is still intact. Skin splits over the limbs, whereby because the muscles have shortened and tightened in response to the heat, the overlying skin has then split, which can look like an incised wound or a stab wound. And then also heat hematomas. So this is when the heat causes the blood vessels and the blood within to bubble through to the extradural surface, and then can cause this appearance that you've got an extradural hemorrhage, when actually it's a finding or an artifact that you would get in fire-related deaths. And it's always worth taking histology in these, because they can still show pathology that is significant and might be of relevance. So these are just a couple of cases of decomposition and just what to look out for and what can happen. So in the left case, this is going to be quite a difficult case in terms of looking at the facial features, but you should endeavour to try and have a look in the eyes and in the mouth as well, and just check the nose is intact. This is all marbling and decomposition effect with then skin slippage. So this is all skin slippage here, this reddening, and there's quite a lot of bloating to the body. And also the scalp also shows marbling as well, so it could be really difficult to see injuries. This is mummification, dry mummification of a hand. The skin can go really leathery and firm. It can discolour the skin, but it also makes it really difficult to then move the limbs and the rest of the body to then see if there are any injuries that are concealed. And finally, this is a case of really advanced decomposition. So you can see there's maggots there, bloating, blackening of the skin, but also this element here is all due to animal predation and scavengers eating and taking some of the tissue. So that may appear like trauma, but actually that is animal predation. This is just an example of what a heat hematoma looks like post-mortem. So you can just see here the lining of the dura at the back of the head. And then sitting here is just a thin film of blood. The difficulty with this is that it looks exactly the same as an extradural hemorrhage on post-mortem CT scan. So this skull needs to be opened up in order for you to be able to discern whether it's a heat hematoma or something else that's more concerning. This is just an example of heat fractures. So you can see numerous fractures all over the skull that's just affecting the outer table, so the inner table is unaffected. You may get cases where, because the body is so badly burned, it's actually really difficult to piece together what parts of the body you have and what is missing, but also just identifying any external elements to this case. But actually, if you adopt a routine approach as to how you're going to handle these cases, maybe by region, this case actually showed that by piecing the pieces of the skull together, there's actually a gunshot wound there. So other things to look for in external examination. It's important to assess for ears and look for injury. Think about the arms and the hands to look for presence and absence of defense type injuries. And this can be really difficult because this can be bruising or incised wounds. But I think the rule of thumb to adopt as a general pathologist is that you will have seen enough cases that you will know what you're happy with in terms of bruising and marks on the forearms. It can be more common, obviously, in people who are elderly that bruise more easily, or other clinical conditions. But I think the rule of thumb is, if you are not happy with the presence of them and you don't feel comfortable that it was within your realm of normal, then you are perfectly reasonable to refer the case to the pathologist, the forensic pathologist. So also look at fingernails to see if there's injuries. Are they chipped? Are they missing false nails? And think about the causation of that. It may be that there's been an altercation. And always remember to look at the perianal area and the external genitalia. So is there any signs of trauma? Are there foreign bodies there that you're not expecting? This won't always be clear in the history, so it's definitely important to do that thorough examination, because you never know what you might find. And then finally, palpation of the main long bones to look for fractures. I'll just go that. So audit results, just going back to the 2012 audit, 9% of initial autopsies that were stopped when there were marks of concern were noted by the pathologist or the mortuary staff. There were 50% of cases that were stopped during the internal examination, and then 41% actually a forensic pathologist was instructed at a later date when the general pathologist had received more information about the circumstances of the death. And this really brings us to a second examination and the problems that a forensic pathologist might face when undertaking an examination. So the difficulty is that there's potential for conclusions to be limited, and it may be because you're not able to do, as a forensic pathologist, able to do a full and detailed dissection of the neck, and it's not possible. You then don't feel that you can comment on that area at all. Provenance of samples can be really difficult. Although samples are taken at the first examination, because you are not able to go through and they haven't been put in forensic evidence bag and you're not sure of the chain of custody or where they've been, it's then very difficult to use those and to be happy with those for a Crown Court setting. That can then make it really difficult if they are then potentially difficult case in order to find more blood or more urine. And so you're then limited on the toxicology samples you can hand over to the police for them to look at. And washing of bodies can really limit the potential for trace evidence recovery, which is why it's so important looking at that decision making by the police really early on to collect trace evidence where required. There are certainly mortuaries where they will strip the body and wash the body the moment they've entered into the mortuary, if it's not a forensic case. So already that process, before you've even got to the case, may have already happened. So thinking about this grey zone when you're really not sure about whether to refer or not, the golden rule is that if there is any aspect of the history or the examination which gives you concern, communicate this early with the coroner or the procurator fiscal. By doing this, you can minimise problems for the forensic pathologist, but you can also maximise the chances of evidence recovery and appropriate examination for any potential criminal justice purpose. So what else can you think about just to reduce that risk of error and make sure that you've thought about a really complete examination? Don't be afraid to ask the police for more information if you're not happy, and you can do that through the coroner and the procurator fiscal. Or ask for photographs. It may be that the description you've got isn't really setting the scene as to setting the scene quite literally as to the scene that is before you, and a photograph may do it more justice as to what you're dealing with. Be concerned about an unusual degree of police interest in a case. Are you being used as a filter? It may be that the police are still not sure and they have sent it through the general pathology route in the hope that you will pick things up. That shouldn't be the case, and there's certainly been steps by the police to reduce that happening. And if you're not happy, discuss the case with the coroner and procurator fiscal and raise it as to why you are concerned. So when I talked about decomposition and fire-related deaths, there were just a couple of mimics that have come up, but they can come up in any scenario. So thinking about lividity and whether it's bruising or not, whether it's true fat embolism or actually it's resuscitation effects that you're seeing in places like the lung. And in cases where, is it a periorbital hematoma or is it actually post-mortem gas as shown in that picture of the decomposed male? And also consider, if it is neck trauma, have you definitely reduced and avoided the element of Prinsley Gordon artifact arising? So that's where the neck needs appropriately draining of blood in order that you don't get any hemorrhage that actually could be contributed to artifact. So this is a good example of how to look and distinguish between lividity and bruising. On the left is lividity. So there you can see there's no extravasation of blood into surrounding structures. There's just subcutaneous. You should just see subcutaneous fat, and if you go deep enough, muscle. And then on the right, this is what a bruise would look like. If you cut into it, you can see that there's blood sitting in the surrounding structures. And this is an example of fat embolism, true fat embolism. So this is a histology slide of the lung. It's sitting right within the blood vessel as you expect, and you can see these fat globules. And this would be a suitable case if you're not quite sure of doing an oil red O stain on. So and that will really pick out the fat globules within the tissue. The important thing to remember about oil redo is that you will lose that evidence on a histology slide if it is fully processed by the lab. So it needs to be an unprocessed, it can be a fresh specimen, but actually you can put it in formalin as well. It's not the formalin that damages the fat globules, it's the process afterwards. So you just need to make sure that your lab is aware of that when you ask them to process the slide. They shouldn't have the same processing as an H&E slide if you want to do an oil redo stain. And then finally, document all your findings, and that really includes relevant negatives as well, because they can be just as useful as the positives, and really mark that the presence of the appendix, the gallbladder, the uterus, fallopian tubes and ovaries, and if you've got things like dentures or false eyes in, to make a note of that as well. And this is my final comment. So this is the Code of Practice and Performance Standards for Forensic Pathology, and this is available on the Royal College of Pathologists website. And this is the Code of Practice that the forensic pathologists follow when performing cases, and this is the standard that they're upheld to. But actually there's an element and a short paragraph there which is relevant to you as general pathologists, which talks about what happens when a case moves over from a routine to a forensic pathology post-mortem case. So I've just literally pulled it out from the document. The code shall only apply directly to cases where the likelihood of serious criminal charges being brought was clear at the point at which the post-mortem examination was started, or when the pathologist performing the examination stops the examination to allow a different pathologist to perform the examination restarted. And it follows that the code shall not apply retrospectively to routine cases if they become the subject of a criminal investigation. So for those 40% of cases where actually they didn't realise until after the post-mortem, this code would then not apply if they become the subject of a criminal investigation, because a general pathology autopsy will not adhere to the same standards as that as a forensic pathology, forensic post-mortem. While the code will not apply directly, that is retrospectively in cases where a criminal investigation is initiated after a routine post-mortem examination, it is stressed that many of the provisions of the code are statements of obligations placed on participants in the criminal justice system. So it is therefore good practice to follow the provisions of the code from the point at which it is clear that there is a criminal investigation. And that's really talking about considering with a case, is there going to be a criminal prosecution or a criminal proceeding? Because if you think there is, and there is a likelihood that it is, then it's good practice to follow what the code sets out. And if you don't feel that that's you, then refer it to an expert in forensic pathology who will follow it to the code of practice. So these are the take-home messages, really. Background information, always ask for more if you're not happy before you start your examination. Always consider the potential of a criminal prosecution when approaching any case. And ask yourself the question in cases of chronic pathology like brain injury, where it's had a role in the death. What was the initial mechanism to cause it? Have you been told it? Do you need to find that information? And if you're concerned, have a really low threshold for stopping the autopsy, and as early as possible, in order that you can maximise the chances in the second examination of answering the questions that may arise. And if in doubt, make a referral to forensic pathology through the coroner's office or the Crown office, and they will be able to assist. Those are my references. And thank you very much for listening. And I'd like to thank Dr. Ben Swift, who very helpfully provided quite a lot of pictures for this presentation.
Thank you, Dr. Wallace, for your time and for presenting this. And we've got a few little questions here that I can read out. But in the last couple of minutes that we have, if anyone else wants to get a question in for Dr. Wallace, they can do that. First is more a statement. It's from Dr. Kemp, who's stating that in a recent audit in the Glasgow department, they found hyoid and thyroid cartilage fractures in around 40% of post-mortem examinations on hanging cases. And my understanding is that that is a similar finding to other studies who have found the same.
Yes.
So the presence or absence of those fractures doesn't necessarily point one way or the other to homicide or suicide, self-inflicted. Question here, how often do you see soft tissue hemorrhage during layered neck dissection in suicidal hangings, as opposed to ligature, asphyxiation, or staged hangings? Is soft tissue hemorrhage in what appears to be suicide hanging always a red flag?
That could be a really difficult one. I think it is very dependent. In cases of complete suspension hanging, I think it's quite common that you won't necessarily see any hemorrhage at all. But I can't remember the rest of that question there, it's just disappeared. But just because you are getting hemorrhage in those cases, it doesn't absolutely mean as a red flag. You need to think about the rest of the context of the autopsy. So is there anything else externally that is also raising your suspicion that something else has arisen?
Yeah, and I think that's also where it comes in with the comments you were making earlier about whether the petechiae that are present are appropriate for the type of suspension that you are being told about, or whether it's incongruous with that. So, can a laceration, such as from a road traffic accident, be picked up on histology? And is it possible to determine sharp force trauma on histology? It's a broader question.
So first, a laceration versus sharp force trauma, those are something that you should be able to identify at external examination. So I haven't seen any reason to take histology samples. I think if you're thinking about that, then it's certainly, you should be thinking more about what you would see externally. So in a laceration, you're going to see more ragged edges, you're going to see bridging potentially of soft tissue sitting underneath this, lower down in the skin. Whereas in a sharp force injury, you're likely to see much cleaner edges on the skin. You're not going to see any of that any of those bridging vessels or veins between. So we've never had any indication to take a histology sample, because your external examination should give you the answer that you're looking for.
Yeah. And also, I think this would be the last question, because we're coming up to the end of the time. Is there any case I should be doing a V-neck incision on for my routine cases?
I think that's quite a good question, because I think personally, from what I've seen, it's very coroner dependent. And actually, the reason being that a lot of V-neck incisions are not done is because you're looking at the fact that the family are going to potentially view that body, and there's not necessarily any indication. It's certainly something we do as standard practice in forensic pathology, but it isn't necessarily standard practice for routine cases. It's quite a skilled examination to do, and it's not something that you necessarily have the time within a routine case. So is there any case, I think if you're thinking of that you're having to do a V-neck incision, you should then be thinking about, actually, is this a forensic pathology referral on that basis?
Yes, I think it should be seen that the V-neck should be the gold standard for examining neck structures if there is a concern with these sorts of cases, particularly considering ligature, strangulation versus suspension. And I think you should be practiced in doing them and understanding how to do them properly. So there is certainly, and if done properly, it should be easy to conceal the incision for viewings after as well. So it shouldn't be seen as something that's disfiguring. I think it's because we're just coming up to the time there, I think we should leave it there. And just as a point of closing, just to say thank you again to Dr. Wallace for taking the time to present today, and for all attendees for joining us. We've had a great turnout today, and I thank you, and I hope that you will return for future webinars. So many thanks.
Thank you very much.